Thank you very much. Thank you, Dr. Barini, for this wonderful invitation, and the chairman, Dr. Baldi, Dr. Porsu. I'm delighted to have the chance to discuss. I think I'm fortunate because I'm coming after Dr. Bari spoke and after Dr. Noyes spoke. Some of my data may be slightly or subtly distinct from that, but I'll just try to flow through it to get to the subject at hand that I will address. I'm speaking today as part of an oncofertility consortium that is in the United States that has been focused at the university where I work at Northwestern. And so this has been sort of the guiding premise, the collaborative work that I've been doing within the consortium. Specifically, what I'm going to speak about today is this dichotomy that's already been addressed about the risk of breast cancer that is associated with ovarian stimulation, both for cancer survivors, specifically breast cancer survivors, but also for patients who are being treated for infertility. So as part of the consortium work, we talk about what the impact of fertility treatments, the impact of oncologic treatments are on fertility. We know that chemotherapy, radiation, and surgery all do threaten fertility, though they've been so impactful on improving survivorship. And as was just mentioned, there are over 1 million patients that are diagnosed with cancer in the United States annually, and over 10 million new cases diagnosed globally, and about 10 to 12% are diagnosed into their reproductive years. And over 10,000 of these patients who are diagnosed as children, 80% are now expected to survive given improved therapeutic options. My specific area of interest, as I'm a surgical oncologist and specifically work on breast cancer, is that there are approximately 11% of breast cancer patients diagnosed under the age of 45 annually. And so in terms of the state of the problem, as has been discussed, fertility preservation for men has been a long-term option. And this would normally be the time where I would talk about Lance Armstrong, though he's fallen out of favor quite recently. But the work that he did, and specifically publishing his book in 2000, really heightened our awareness about this issue. I think the reasons why we have such a difficult time implementing fertility preservation are the gaps that Dr. Bari actually mentioned using this exact term yesterday. There's an information gap. We don't know a lot about the impact that the treatments are going to have for patients and providers, and I'm going to try to address some of that today. There's also a data gap regarding the precise gonadotoxicity of cancer drugs, and I think we're learning more about that, but it's been particularly challenging to study. And there's also an option gap in terms of communicating breakthroughs and changes like this new announcement from ASRM about the change in the experimental title of oocyte freezing from just a month ago, making that clear to the patients so that they understand that this is a viable option for them to participate in. I just want to briefly talk a little bit about infertility and survivorship. We know that the infertility is associated with a diagnosis of depression that is quite significant for patients who are affected. Adult survivors of childhood cancers report feeling increased anxiety and finding a mate and not really being prepared appropriately for the long-term effects of their treatment. Work that we did in a survey study has shown that young men and young women do have equal concerns regarding their fertility. But the thing that is most profound for me as a breast cancer surgeon is that young breast cancer survivors, 57% in one study reported that they had substantial concerns about their fertility, but that 29% said that this concern was going to affect their willingness to take chemotherapy. And so I think this is a pivotal thing we have to consider when we talk to our patients and when we avail the options that are currently considered safe for them. That this may not impact only their chances of having a child, but it may impact their survival, and so in that sense has a very significant potentially therapeutic impact. Now flipping the coin towards the impact of fertility treatments on the development of breast cancer. Increasingly, as we just saw so elegantly discussed by Dr. Noyes, is that increasingly women are delaying childbirth. 9% of couples worldwide experience infertility. Approximately 56% will seek medical care. About 20% of patients in the United States will have a first child after 35, and about 1/3 will have fertility problems, and maybe I'm slightly off here, Nicole, I don't know, but this is the data that I have. These patients opt for fertility treatment now at an age when breast cancer incidence is increasing. I do want to place some perspective on this, though. We do have about 200,000 new cases diagnosed in the United States annually that are invasive, about 18,000 patients under the age of 45, but the majority are over 35. So this is where there is this intersection between increasing risk. We know breast cancer is an age-associated event, and the risk for infertility increasing also after the age of 35 to 37. So what my charge today will now be to talk a little bit about the impact of infertility treatment, estrogen, and the estrogen exposure risk for these patients, both survivors, breast cancer survivors, and patients contending with infertility treatment. So just a little bit about breast cancer. It most commonly forms in the undifferentiated terminal structures of the gland. These are the ducts and lobules that are at the peak of replication around early adulthood, and this is when they're likely to be most susceptible to carcinogens. These have a high estrogen receptor content, and this will increase because of the mitogenic component of how ER focuses on cell cycle control, can increase susceptibility to the exogenous or epigenetic events that could lead to increased risk of breast cancer. We know that there is a protection of early pregnancy and multiparity, but this early pregnancy protection is like at age 18 and 19 and 20. And so this tends to be suboptimal for many of us, considering a long-term career to have a child at 18 or 19 to decrease breast cancer risk. The consideration is such, though, that if you could push through an early pregnancy and lactation, this is what will allow the breast to become truly differentiated and would be most robust against the different epigenetic phenomenon that would increase breast cancer risk. Prolonged estrogen exposure, late pregnancy, nulliparity, these all are things that potentiate the risk for breast cancer. In terms of estrogens in breast cancer more specifically, about 60 to 70% of patients diagnosed with breast cancer are considered ER positive, and that's basically any amount of estrogen receptor positivity above 5% most generally. The estrogen receptor is normally expressed in low levels in the normal breast, but these levels will increase with premalignant lesions, with the highest levels being found in patients who have ER-positive cancers. It's thought that in the normal gland there may be a subset of estrogen receptor-positive cells that are the mammary stem cells and may have the capacity to self-renew. And these may be the things that then allow the breast to ultimately go on to differentiate. And it's theorized that aberrant proliferation of these ER-positive stem cells leads to the large ER-positive cell population that's found in the majority of breast cancers. So why do we really care? It's because, as I mentioned, estrogen is a mitogen. This is something that is going to drive cell cycle and increase the risk for mismatch repair or other mismatch damage, or mismatch repair not to occur, or other damaging events to occur that could lead to cancer. So it's the interaction of other hormones, growth factors, and cytokines. Estrogen, progestin, I think, is a very highly debated topic, that activate proto-oncogenes and other mitogens like c-MYC and the cyclins to progress the cell cycle forward. These genes mediate G1 to S transition, and it's thought that the increased exposure of estrogen may facilitate this malignant potential of these cell cycle regulatory proto-oncogenes, establishing this concern between estrogen and malignant transformation in the breast. So I'm going to just sort of fly by how Clomid works, because I think you're much more expert in this subject than myself. But the thought is that, and I think it's the case that cycles where where there's ovulation induction through Clomid, serum estradiol levels are greater than in naturally cycling patients. And high progestin levels that occur from multiple follicles may have some impact on breast cancer risk. In terms of Clomid from the basic science perspective, this is actually considered a very friendly drug because it's a selective estrogen receptor modulator similar to tamoxifen. In fact, their birth was the same. Tamoxifen and Clomid were both designed along the same pharmacologic lineage. So it's shown to inhibit MCF7 cells, which is a well-differentiated ER-positive breast cancer cell, through blockade of the ER, as well as calmodulin antagonism. Calmodulin antagonists will inhibit cell proliferation in breast cancer cells, and this is the site of early action of the early G1-G1S boundary. So it's thought to have an early effect on the inhibition of cell cycle progression. So it's also been shown to inhibit the progression of breast tumor xenografts, and has also been used in clinical trials years back for the treatment of breast cancer, though was found to be significantly less effective than tamoxifen. In terms of IVF, I think this has also been nicely covered by Dr. Noyes' talk. We know that patients who are being stimulated are going to have higher levels of estrogen than those patients who are undergoing natural cycle. The question really is, does this estrogen exposure have impact on the long-term outcome for patients who may be at risk for breast cancer or for recurrence? There's conflicting data about the expression of the HCG-LH receptor in breast cancer cells, but I think this is something that's been really fascinating for me, and it's that HCG has been found to prevent estrogen-induced tumor progression in breast epithelial cells and to potentially promote cell differentiation. The well-differentiated breast cancer cells that are ER-positive that we used in most of our model systems to study breast cancer actually have high levels of HCG-LH receptors and are responsive to HCG, which I'll show you. HCG also has anti-invasive and anti-proliferative receptor-mediated effects down-regulating master cell regulators like NF-kappa B and AP1 in breast cancer cells. So this is all sort of the flip side about the deleterious impact of estrogens may be this beneficial impact that HCG may have. So to segue on in terms of what the options are currently for patients who are breast cancer survivors and for patients who may be contending with infertility, something that's been well discussed already in the meeting: pregnancy, embryo egg banking, ovarian cryopreservation, ovarian tissue transplantation, donor egg, and adoption, as well as surrogacy. What I'd like to do now, moving on to some of the data from the talk, is just discuss some of the background on why these questions became a source of interest to my lab. So I'm going to just go over some of the most, I think, widely discussed studies on the impact of fertility treatments on breast cancer, and so I can point out to you what they are and then talk to you a little bit about the concerns that are associated with them. And so the first one I want to discuss briefly is the NIH fertility and breast cancer study that was published in 2003. This was a population-based multi-center case control study, and thousands of patients in it, over 4,000 cases and 4,000 controls. This study showed that a history of fertility drug use was not associated with breast cancer risk, but when comparing patients who were treated to patients who had never been treated, over 6 months or cycles of ovarian stimulation through HMG was associated with a significant increased risk above the baseline untreated population. In 2004, there was a French study that was also looking at over 90,000 patients participating. 6,000 were treated for infertility, and during a 10-year follow-up, over 2,000 invasive breast cancers were detected, and 183 patients wrote down that they had been treated for infertility. And there was no association in this study that was found between treatment for breast cancer, between treatment for infertility and the development of breast cancer. But this is one of the first studies that started pointing towards significance of family history. So there was family history data in here, which was it's important because that's such a significant confounder in how these studies are approached. But the cause of infertility was unknown, and this was another significant confounder because we know that patients with non-ovulatory infertility may have a greater risk of developing breast cancer. In 2006, a paper came out of Israel. I think this is possibly one of the most widely cited studies on Clomid, looking at using two different approaches, a historical perspective cohort as well as a nested case control, which was really, I think, the sort of key part of this study. It was thousands of patients, but it was from an older patient selection population, from farther back in time, from 64 to 84. Clomid was associated with an increased risk for breast cancer in the general study, but in the nested case control, this actually was more substantive. as well as cycle index being reflective of greater risk. So longer exposure to estrogen over one's lifetime and longer exposure and Clomid exposure was also associated with a higher risk. Then in 2008, another study from Israel, a retrospective cohort analysis was done looking at patients who had just gone through IVF. They found 35 breast cancers in over 3,000 patients that were treated with an expected cases of 24.8. So there was a higher number of breast cancer cases found than what was expected. There were some risk factors in this population. Age over 40 years, but we know that age is associated with breast cancer risk, hormonal infertility, and greater than 4 cycles of IVF. But in this study, too, 29% of the patients had a positive family history, so this is also a modifying factor. In 2009, there was another study that came out of Sweden. This, too, pointed toward more than 4 cycles of Clomid being associated with an increased risk for breast cancer. And I just want to get up to this study. This is a 2010 meta-analysis that was published. I think this is another very important paper because I think it places into context much of all of the literature that has been published up to this point in time, including the ones that I just mentioned. So 22 papers, a total of 23 studies, and overall no association with the use of fertility drugs and breast cancer was found. The long-term follow-up was recommended, and there were several inherent weaknesses with the data that were discussed that I'm going to get to in just a minute. I think this paper also achieved a high amount of attention. It is a very recently published paper in the JNCI, which is called the Two Sister Study. This is the last study that I will specifically mention. Sister-matched case control study for patients under 50. What it found is that treatment and no pregnancy, they looked at 288 patients who developed breast cancer, and they were case matched. 193 used Clomid, 29 used FSH, 66 used both. The keys from this study, treatment and no pregnancy resulted in a decreased risk for breast cancer. Treatment and up to a 10-week pregnancy was associated with increased risk, though this risk was not found when compared to untreated controls, patients who had never gone through fertility treatment. There were several weaknesses of this study, which the authors acknowledged, that the data collection was all done through self-reporting. None of it was substantiated through medical records. There was no family history, no follow-up of pregnancy outcome data, so we don't know what happened with these pregnancies after 10 weeks. So I just wanted to briefly go over some of the problems that have existed with these epidemiologic studies. So in many of them, we don't know drug type or dose. There's a varying length of follow-up. There's significant heterogeneity in the patient populations that have been studied. There's a lack of information about progestin use and estrogen levels during stimulation, a lack of information regarding treatment outcome, read the full-term pregnancy data that I had mentioned, a lack of information on patient age at the time of treatment, which is such an important confounder, no information on oral contraceptive use, a lack of focus on causes of infertility, as well as a lack of data on family history in many of the studies. And so where this leads us is, what can we say from these epidemiologic outcomes studies? I think that they're largely reassuring, but we have to understand that there are significant flaws that are very difficult to circumvent. So with this in mind, we went to the lab, and we said, maybe this is an example where the lab can help us to try to address these and begin to address some of these questions, if it's so hard to do this in a population-based mechanism. So what my group sought to do is examine effects of these infertility treatments on hormone exposures in vitro. We used the cell lines. The MCF10A cell line is considered a normal, immortalized breast cell, so a good study for considering the patient that has not had breast cancer. It's a normal cell. It is relatively ER/PR negative or hormone insensitive. We also looked at well-differentiated MCF7 ER-positive cells, as well as a breast cancer cell line called HCC1937, and these are breast cancer cells that are ER/PR negative, but also have a mutation in one of the breast cancer-causing genes, BRCA1. And we looked at FSH, LH, HCG, Clomid as well as estrogen and progestin, and we did proliferation assays and 3D culture. So very simple study design. And to just take you through the data quickly, what we found was that estrogen and Clomid in the normal breast cancer cell model, that estrogen and Clomid did not have a significant effect on cell proliferation or colony size, so it was not considered a stimulant for proliferation. Progestin and increasing doses of HCG, and you can see this here too, higher dosages of HCG actually caused a decrease in cell proliferation and colony size. We then looked at ER-positive breast cancer cells, and we found actually that as it was just a really exciting finding for us that increasing dosages of HCG resulted in decreased cell proliferation, and that was found in both in cell proliferation assays as well in three-dimensional studies where we put tumors and we grew tumors and then we treated them with these agents. We found that HCG caused it to decrease, as did progestin. And I think progestin is just a very controversial topic and very unknown about how it's impacting breast cancer risk. We did see, and this was something that the editors, when we were publishing this work in Human Reproduction, they did want us to show substantively, though, the impact that escalating dosages of estrogen were going to have. And you can see here that increasing dosages of estrogen did cause, as expected in an ER-positive cell line, increasing tumor size as well as increasing cell proliferation as estrogen dose increased. So I think that that speaks to the real sort of, important thing to show from the work. In our ER-negative BRCA1 mutated cell line, we actually saw very little impact, though at the highest dose, we did find that HCG was also able to inhibit proliferation in this cell line too, which I think is really exciting. We actually then had also, in our original paper, which I think this is so interesting, looked at the impact of FSH and LH and FSH and LH together, as well as FSH and HCG, and we had included this data in our original paper to Human Reproduction. But because all of the data is negative, so we see no directed impact on really any of these treatments in a substantive way to cause cell proliferation or increase tumor size, the editors wanted it out. They said, this is all negative data. We don't want it. I said, great. We'll make it into another paper and submitted it to Fertility and Sterility. I mean, I think on some levels we know that negative data may be the most important data, and I think that for this meeting this actually may be the case. And so I think this was largely reassuring to us. There does not appear to be a directed stimulatory effect. So what to take from all of this together? I think we see that estrogen does increase cell proliferation in ER-positive breast cancer cell lines, and it's significant that 70% of patients, as we mentioned, are ER-positive. HCG and progestin result in a decrease in cell proliferation. Clomid, FSH, LH have minimal impact on cellular change and no impact on proliferative effect. The primary deleterious impact may stem from the escalating estrogen exposure in patients who have occult ER-positive lesions. The opposing effects of estrogen and HCG lead us to the hypothesis that high HCG levels are associated with healthy pregnancy could potentially be that balance to mitigate the estrogen-related effects associated with ovulation induction agents. And there's just two more things I want to bring up, and that's the timing of pregnancy and recurrence. As a surgical oncologist, I used to be more comfortable saying wait 5 years until you have a baby. There is no evidence that waiting any amount of time really changes the risk of recurrence inherent for a patient who may have one. So we no longer discuss that. In regard to tamoxifen, for young patients who are ER-positive, my wish would be that a patient could be on 5 years of tamoxifen. That tends to not be, I think, work well with many patients, young patients' life plans of having a child. Now we are modifying that recommendation, suggesting if you can take tamoxifen for any amount of time before you're ready to have a baby, go on it, then go off it. Obviously, you do not want to get pregnant on tamoxifen, so you need to be very mindful that the patient is off of it because it's a significant teratogen. Go off tamoxifen, have the baby, go back on tamoxifen. You'll still obtain benefit from tamoxifen, especially up to the 5-year endpoint. I want to talk a little bit about what's known in regard to the risk of pregnancy after cancer, and I think that as we're running low on time, the message to be taken is that it is largely reassuring. This is a paper out of MD Anderson where I was a fellow, a cancer center in Texas. Basically, the incidence of recurrence was 23% for patients who are pregnant and 54% for patients who are not pregnant. This points towards the fact that pregnancy was not associated with an increased risk of disease recurrence or poorer survival. There are 8 other studies that corroborate these findings. 2 that actually suggest a protective effect that may be associated with becoming pregnant. And but there may be an increased risk for miscarriage in these patients who are cancer survivors. So just 2 more slides. I wanted to put this up quickly, not to spend a lot of time talking about it, but I think that back in 2009, myself and my collaborator from Northwestern, Dr. Teresa Woodruff, we put together this algorithm and we published it in the New England Journal to talk about how breast cancer patients can be approached. So if you're interested in just seeing how we think through the problem from an oncologic standpoint as we are making this referral over to the reproductive endocrinologist, this is some of what goes into the thought process. And so lastly, I just want to conclude by saying, in terms of the potential for treatments to cause breast cancer, I suspect that for patients with repeated exposures, for a subset of patients who are at higher risk, that this may be or may have some impact. And may be an impact for patients who remain nulliparous and who never develop a pregnancy and don't see that beneficial impact of high HCG levels. For the patients who have had breast cancer, I think, it's going to be difficult to discuss whether or not ER-positive lesions may increase recurrence risk. There's no data to suggest that subsequent pregnancy does increase risk, but it will be hard for us really to ever address this question prospectively in the most rigorous way, because what are we going to do? Take a bunch of breast cancer survivors and say, you all want children, but you have to be randomized to no baby, and you'll be randomized to baby? That's never going to happen in human nature. So ideally, I think we need to focus on a treatment plan that minimizes estrogen exposure and results in a successful pregnancy. I think you do have to mention the option of surrogacy for your patients who are young and ER positive as another potential source of mitigating risk. I just want to also end by showing you this is my lab, and these are some of the people that did the work, Ann Cooley and Elizabeth Tarsowitz. And actually, this is another one of my former fellows, Laura Matthews, who's an OBGYN resident at Northwestern. And this was my postdoc who did a lot of the FSH works, Dr. Samir Boukati, and he is a chef de clinique at the University of Nice in the south of France, and really a magnificent guy. I hope you have the chance to meet him. He was just a wonderful, wonderful colleague to have when he was in my lab, now in France. So thank you very much. I'm happy to take any questions.